Hello, my name is Israel Dowd. I'm the Neuro Interventional Coordinator here at Sutter Medical Center, Sacramento, where we were the first Sutter hospital to become a comprehensive stroke center in 2021. Our ability to give complete 24/7 care for stroke victims significantly improves patient outcomes and long-term functionality. Our treatments include ischemic stroke and hemorrhagic stroke. Comprehensive 24/7 service includes neurointervention, neurointerventional radiologist, neurointerventional team, vascular neurosurgery, neurocritical care services. 2021, we were awarded the Stroke Gold Plus Quality Achievement Award, and this year we're looking to up it up with a Platinum Plus Quality Achievement Award. There are two types of strokes for the brain: hemorrhagic and ischemic. In the last few years, we've talked about ischemic stroke and time is brain and trying to get the clot out as fast as we can and moving fast and moving along quickly. Today, we'll be talking about hemorrhagic stroke or bleed in the brain, which is a little more precise, and there's actually a path that we take to help treat these patients. There are four types of intracranial hemorrhages: epidural, subedural, subarachnoid, interparenchymal. We'll be talking about the subarachnoid hemorrhage, which is the most severe. This means that there's blood in the space that surrounds the brain. Most often occurs when a weak area in brain blood vessels, such as an aneurysm, bursts. The blood then builds up inside the skull, increasing pressure of the brain. Three main causes of subarachnoid hemorrhage: smoking, high blood pressure, drinking alcohol. 10 to 20% subarachnoid hemorrhage die before getting to the hospital. 25% die within the first 24 hours. There are two ways to treat these patients who have subarachnoid hemorrhages. We have a clipping versus coiling. The clipping is where a neurosurgeon will take the patient to the OR, take a burr hole through their skull, through their brain, down to the aneurysm, and put a platinum clip across the neck of the aneurysm. And we have coiling, where we will put a femoral sheath in the femoral artery, take the little catheters into the brain through the blood vessels, and put these little coils and protect the aneurysm from rebleeding or growing bigger. Diagnostic team roles in the care of the hemorrhagic stroke patients. CT helps diagnose patients with bleed in the area of interest. IR provides treatment for hemorrhagic stroke and vasospasm. Ultrasound helps diagnose vasospasm with daily TCD surveillance. So as you know, we all get the stroke alerts and we move fast, and the patients go straight from the ambulance and they come straight through and they go straight into CT. And the first thing we look at is a non-con CT head, and we want to see if there's a bleed. So if there's no bleed, then we go to the steps of ischemic stroke and we try to work that patient up for a blood clot. If there is a bleed, we basically slow the process down, and we go with a methodical approach of how we're going to treat this patient. So the patient will get a head CT. We'll find like this patient, this 32-year-old female who's 4 days postpartum. She presented at SMCS with an aneurysmal subarachnoid hemorrhage, which this is the typical look that you get, the funky chicken. You also see on our left side of us is a little blip. That's probably where the aneurysm bled. So we have an idea that we do have blood in the head, and we have an idea of where it actually bled. So once the CT is done, completed, we move on to a CTA, head and neck. And here's our CTA, and you can see that there is a posterior communicating artery aneurysm. So the neurointerventional radiologist is consulted for a cerebral angiogram and aneurysm embolization. If this patient cannot be embolized with coils, that's when we will get a consult from neurosurgery and take them to surgery. So this patient was consulted by neurointervention. This patient left the ER after their CTs and they went to the ICU, and they actually get stabilize these patients and make sure that they're good to go, tee them up, make sure there's nothing good for their surgery, so they're cleared for anesthesia, and if they need a drain before we get drains and so forth. This patient didn't need any of that. So they came down for their aneurysm, embolization, and we did the angiogram, and you can see here, this view shows that there is a 5 to 6 millimeter PCOM aneurysm, and this aneurysm has a little daughter lobule, and you can see it right there at the tip there, and that's where the patient had blood from. There's a lot of times that we see these aneurysms that bleed. You can see the little daughter sac there, that where the bleeding is coming from. We were able to put 3 coils in this patient and secure them. We secured the aneurysm so that it wouldn't rebleed, and we could actually medically manage this patient for vasospasm if needed, with giving them fluids and getting blood pressure up, so that we push flow through the brain, so that there's no stroke-like symptoms with vasospasm. This patient actually got upstairs after we embolized the aneurysm and was still a little sick, so they did a CT, and the CT demonstrated some developing hydrocephalus. So neurosurgery was consulted, and an extra ventricular drain was placed for intracranial pressure monitoring. So if there's a lot of blood around the brain and there's pressures on the brain, this actually, we can open this up, and it'll flow out and take the pressure off the brain so that it doesn't build up. Or we can they've done in the past, they take part of the skull, if it gets really bad, they take part of the skull and put it in the belly and keep it like that, but that's very extreme, but it does happen. So once the patient gets bedded after our aneurysm coiling and they get to ICU, they're going to spend at least 2 weeks in the ICU. When doing so, they will put on vasospasm lookout. What does this mean? This means that the patient will get TCDs every day, because the window for vasospasm occurs between 3 and 14 days post bleed. We try to manage that vasospasm first with neurology, and they medically manage these patients with different types of drugs and therapies. But we continually get TCDs every day to surveillance for the vasospasm development. Normally, MCA velocities run about 62, and if you have significant spasm in the MCA, it goes about 120, severe spasm about 200. This patient on day 4, her right MCA was 278, her left MCA was 226, her Basler was 55. So Dr. Varjman was consulted for a vasospasm treatment. So we brought the patient down, and let's look at our first treatments. Our first line of defense for vasospasm is medical management. And then we can do intra-arterial verapamil, which is a vasodilator to help open up the vessels. And then intra-arterial angioplasty. And those are for patients who have severe vasospasm, and there's really narrowing of the blood vessel. And it's one of our last ditch efforts to help get vasospasm. So you can see in day 1, day 1 is going to be the day that we treated her. You can see that the coiling, the aneurysm hasn't been coiled yet, so you can see our flow on the left. You can see there's flow getting through there pretty good. At day 5, when we brought her down for her first vasospasm treatment, you can see the narrowing and the slow flow getting through the right middle cerebral artery. And so those are our velocities we saw at like 275. So on day 5, we gave some verapamil to the right ICA, 20 milligrams. And you can see right here on the picture on the right that this opened it up a little bit. And then we give another 10 milligrams of verapamil in the left ICA and 10 milligrams in the left vertebral artery. The reason why we do this is because the vasospasm is caused by irritation. It irritates the blood vessels around the brain that the blood could be at. So it could be anywhere. So if there was any pressures on it, that's when the blood vessel gets irritated and goes into spasm. So that was our this lady, our course of treatment was for radiology across the board. We obviously did our CTs at the beginning. We did our CT for hydrocephalus. And then we also did 11 days of TCDs. We did 7 days of vasospasm treatment. On day 20 of her bleed, she was discharged to Sutter Rehab on July 18th, and she was discharged home July 15th. It just shows you all the work that this goes into with neurology, ICU, neurointervention, radiology, ultrasound, CT, all the work that we put into this to help these patients get through these tough days and help them get home. So in summary, SMCS is a comprehensive stroke center that has the capabilities to treat patients that have ischemic and hemorrhagic stroke to include aneurysmal and AVM ruptures. Diagnostic image is an integral part of treating and diagnosing stroke patients to include CT, IR, and ultrasound. The care we provide has an immediate and lasting impact for patients that have life-threatening bleeds in the brain. Thank you for all the work you do. And the last thing we always want to pass along is the BFAST. This is the Heart Association's stroke-like symptoms, which is B is balance, E is for eyes, F is for face, A is for arm, S is for speech, time is for T, or T is for time. Thank you very much. What did we get under? That's pretty quick. You're going to be in production now, video production.
Video production. Okay, stop.